study computer science and cognitive science. And she likes to spend her birthdays at Taekwondo. And the next skill she has to master is folding laundry crisply.
Hello. Tonight I have the pleasure of introducing Dr. Sheila. She's absolutely a wonderful person to get to know. A past delegate and staff member hailing from Iowa. A distinct memory that has stuck with her is her first overnighter, where she trekked the 14 miles of the North Fork Trail. When asked if she remembered anything weird about camp, she mentioned how with every meal that was served, grapefruit was always served in some shape and form, though she doesn't particularly like grapefruit juice. When asked the important question of Marvel versus DC, she said the correct answer, and more obvious, Marvel. Particularly when she had her birthday dinner, she watched Avengers Endgame. However, when it comes to vigilantes, she would like to be Catwoman, not just because she's fast or strong, but because she is non-named or has any distorted features of any kind. Lastly, when questioned about her thoughts on the character Baymax from the movie Big Hero 6, she said that she believed that he may possibly be a reality in the future. Thus, without further ado, Dr. Sheila.
Thank you, Sheila. Now, I don't know that any of the products I've worked on are going to quite compete with Betamax, who I have to kind of remember from that movie. I had a little help on that. But hopefully, I'm going to take you through a little tour of the medical device world, but everything's going to tie back to bones, balloons, and bicycles, which are three of my favorite things. So, I wanted to start out just by asking if anyone has used a medical device today, and to kind of give you an idea, and I'm thinking several of you are still wearing some of the medical devices from an earlier directed study.
We took them off.
Oh, you took them off? Okay, but so what kinds of medical devices might others have come into contact with today?
Let's start simple with a Band-Aid.
Band-Aid? Yes. So you know Band-Aid is actually a medical device.
Glasses.
Glasses, another one, so most people have had.
Consumable medicines or pharmaceuticals.
Medicines and pharmaceuticals are actually very medical. Many of them are not actually devices. They're actually in a whole other division of FDA under drugs. So, but is there anyone who thinks maybe they haven't come into contact with a medical device today? Oh, we got a couple. And so before I put it on the spot, have you brushed your teeth today? That's one question. But it's very rare for us to go through an entire day without coming into contact with some form of medical device. Now, part of that reason is because the definition is very broad and all-encompassing. I actually shortened this down quite a bit, but it's basically anything that is used in the diagnosis, cure, mitigation, treatment, or prevention of disease in man or animals, got to throw those in there too, or intended to affect the structure or function of the body of man. Okay, what doesn't do that? So that gives FDA and other places that regulate these things a really broad range of things that they need to keep oversight on. So medical devices are everywhere, and they're really covering a lot of different areas. So how did I even get into this area? Just because you're all getting ready to go off to college and start your educational path, my educational foundation is really rooted in bones. I did my undergraduate at the University of Iowa in biomedical engineering. For me, I love the engineering, but the medical side always made it way more interesting than just the other mechanical stuff that we were doing. Also in biomedical, I got a little bit of bioelectrical, biomechanical, and also biomaterials. So I thought I was getting a lot of all the best worlds rolled up into one. I went on to graduate school, got my master's and PhD at Stanford. And what I was working on at Stanford, very early on, I took an elective on developmental biology. And I just If you ever get a chance to just explore that a little bit, I just found it fascinating. Even though I didn't really make a career out of it, it's always neat to just kind of go and scratch the surface on some of these topics just a little bit. What you're looking at here, you can kind of tell it's a developing fetus, and you can see a lot of the skeleton on there. But not all the skeleton is there. During the developmental process, everything starts out as cartilage in the skeleton, and then it slowly turns into bone. Well, there's two ways that that bone can turn, or that cartilage can turn into bone. One is called intramembranous formation. So you can think of that as there's kind of a lattice of woven material and fibers, and then bone gets laid down on that lattice. The other kind, which is at the ends of that kind of generic bone that I've drawn on the slide, is called endochondral ossification. So endochondral means it's basically where the cartilage is basically turning into bone. So when you're looking, if you imagine all these white spots on this developing baby as being bone, what you're really seeing is all those parts of the long bones that have already turned into bone from the intramembranous formation. Okay? Now, if we took this a little bit later in time, at the ends of all those long bones, there would be a little space of cartilage, and then we'd start to see all these little dots start to appear. All these little, what are called ossification centers, or little centers of bone that are forming. And that's really what I spent a while studying for my thesis. But if we look at kind of how a long bone develops generically, it starts all out as cartilage cells. There's something missing here that's in the next slide. All of these blood vessels that are going in. Cartilage is avascular, or without any blood supply. That's one of the reasons, if you've ever heard someone getting a knee injury or they injure their cartilage, and have you ever heard that cartilage doesn't heal very well? One of the problems is because it doesn't have much of a blood supply. That's one of the main ways the body will heal itself. So these blood vessels are all invading the bone and keeping that bone growing and happy. And at the ends, we've got all cartilage. Then we start getting these little circles of bone that start forming. Okay? And then they start to expand, and then we'll start getting kind of a plate of cartilage, which is, anyone know the word for that at the end of the bones? Growth plate. And that's how your bones continue to grow longer during this process. And eventually, those growth plates will close, kind of like the lower right, and then at that process, and it won't be the same at the ends at both ends of the same bone, but hopefully in the end you're going to end with these nice articular cartilage layers in all your joints where they rub against each other. So my thesis was looking at what's going on the cellular level, what's going on there, and we find this really neat process of endochondral ossification, where first the cells would all start proliferating and dividing, just getting more and more of them. Then they'd start to get big and fat and happy, or hypertrophic, and then eventually they would start mineralizing and turning into bone. And so, in the end, what we were really looking at is how can we impact that process with mechanics, or how these bones and tissues are being loaded, and drive understanding what's happening on the biological level by understanding what's happening on the mechanics level. So, spent a long time being pretty much a bone geek, but loving that I was finding out how and why you ended up with this nice layer of cartilage in a healthy joint, and what types of things were going wrong mechanically that articular cartilage would degrade or go away over time. So, finished graduate school, and so now I'm this bone expert. What do bone experts do when they grow up? If you knew, that'd be great, because I didn't know. But I ended up finding myself being drawn into the medical device world, and partially because that's where a lot of job opportunities were, and where people understood what engineers could do. And I was lucky enough to find a company where I could work with that. In new device or product development, there's always some common themes, and this is not unique to medical devices. This is across all products that might come across or developing. You have an unmet need. Somebody needs something to happen, and if you have a really good idea of how to solve that problem, you're on a good path to have a product that might become marketable. It does have to work, it needs to be safe, but if there's 14 other ways to do the same thing you're trying to do, it's probably not going to be that great of a product. But this general construct will get you a lot of the way through understanding which devices end up being marketable and which ones don't. So we're going to kind of keep that framework as we go through this talk. This next slide really focuses on what my first company was looking at. This is a condition called kyphosis. When you look at this slide, what I see is the progression of the disease called osteoporosis. In osteoporosis, you may have heard of it. It's when the bones will get very thin and brittle and maybe fracture. Oftentimes it might be, you might have heard of like osteoporotic fractures of the hip or the wrist, or sometimes even the calcaneus, which is the heel of your foot. But it's very, very common in the spine. So if you look at this picture, if you can imagine that this is a daughter, a mother, and a grandmother. So maybe similar genetics, similar lifestyles, but it's different stages in the progression of the disease. And what's really happening is if we look at their spines, there's the actual bones in the spine are actually fractured and compressed. And as it progresses, if you have one or two, you get a little deformity, but if you have more than that, you can get these severe deformities that occur. When I was growing up, I just thought, well, maybe they had really bad posture when they were growing up. That's why everyone told me to sit up straight when I was slouching. But that's still a very good idea to sit up straight. That's very good for your biomechanics, but this is a much more detailed the whole side of the room just like got an inch taller in their seats. So let's take a closer look at the anatomy of the spine. This would be a normal spine. And I'm sorry, I'm trying to remember. Yeah, I do have a pointer. That doesn't, can you see that pointer?
Yeah.
Okay. Okay. So it looks, yeah, it's on the ceiling.
It bounces off the TV.
Oh, is that what it is? Okay, thank you, sorry. But each one of these squares of these bones are called the vertebra in your back. You may have heard that word. But the squares themselves are called the vertebral bodies. In the back, you have these spinous processes. So if you, and those are the bones that if you feel the back of your bone, the back of your spine, and you feel these little bumps, those are all your spinous processes stacked on top of each other, okay? So in a normal spine, all the load is going through the vertebral column, and it's just, everything's nice and happy. And if you look at the actual bone, it's this very strong, lightweight material. From an engineering material point of view, bone is really cool. And when it's healthy like this, it's actually very strong for weight pound per pound compared to a lot of other engineering materials. What happens with osteoporosis is a lot of that bone starts going away. And you get this, you start to get big voids. The connections that are there are much thinner, they're not as strong. And part of that is due to mechanics. There's also hormonal components, and there's all sorts of other, could be drug related, like a lot of steroids and things like that will attack bones. So there's lots of different reasons the bone can get to that point. But the end result is that you can start getting these fractures that then create the deformity. And it's very much a progressive cycle. Now, you notice that I mentioned that normally the bones or the forces are going to go right through that vertebral column. That's not possible now when it's curved over there. When you're standing normally with a straight spine, your head is aligned with your spine. How much does a human head weigh? The movie Jerry Maguire says 8, so that's my reference. So, but if you think you've got this 8-pound weight that's normally sitting on top of your spine, but now suddenly it's off to the front, that creates what's called a moment arm, and it actually puts even more force on the front of these bones that are already compromised because there's less material there. And then what can happen is, well, then the next bone wants to fracture. And then what happens? That 8-pound load is moved even further out, okay? So that's kind of the progression. So what do you do with a broken bone? Fix it. If someone didn't say cast, I was going to be like, where were you today? Yeah, so how do you cast a spine? A brace, rods, those are, yes. So when you think about a brace or doing something from the outside, and these are definitely medical options that were available. Can everyone do me, just take a deep breath. Did your spine or shoulders, did your chest raise, were you completely still when you breathe? Your body moved. If you have a broken bone, especially in your spine, that's painful. That's like any other bone. Has anyone broken a bone? I never have. But did it hurt? Yeah. Just because it's in your spine and you can't, move it, it still hurts like a broken bone. So these patients with these fractures, every time they take a breath can be painful for them. Imagine if you're coughing, or if you sneeze unexpectedly. The pain was really a problem. But casting, even if you had a brace on, if you took that breath, it would reduce your motion a little bit, but it's not a solution. You also mentioned rods and screws. Rods have to be attached with something. You've ever tried to attach a screw into wood that's rotted or wet or not very solid? That screw's just going to pull right back out. So now if you've got rods and screws that aren't secured, now you've got moving hardware next to a broken bone, maybe even pivoting inside of a broken bone. You've made things a lot worse, and you've subjected the patient to a pretty extensive surgery to get to that point. So that wasn't a solution either. So at this point when I was working with this company, compression fractures were really they weren't fully understood, and they were definitely an unmet need. There was really no treatment for them. There's 1.5 million of these fractures in the United States every year, and basically the only treatment was painkillers and bed rest. And if you think about the population where this was happening, older individuals, they still had a lot of good life left, but we were basically saying, putting them on painkillers and bed rest, two things that were not going to really help their life, their health in many ways. Because as soon as you stop moving, even other bad things can happen. So we definitely had the unmet need thing. So was it a good idea? Well, the company, the founders had this idea, let's try to fix it from the inside out. And minimally invasive. They didn't want to do an open surgery. They wanted to do as small of a hole as possible. So their solution was to come in with a balloon. Because maybe you don't quite know. But basically they would come into this fracture that's kind of angled. They would inflate that balloon, try and put that fracture back where it was supposed to be as much as they could. Even if they couldn't get all of that anatomy back, they would create this nice big hole in the bone. Now, maybe that doesn't sound like we're fixing anything quite yet, but we made this nice big void. We would take the balloon out, and then we would fill that bone with, at the time, what was called bone cement. And then that bone cement would then carry the load of that bone. And then suddenly all the motion was stopped, and the anatomy was possibly restored, or at the minimum, the pain was taken away because that fracture had gotten some treatment. And as far as the extensive surgery, this incisions were covered with a Band-Aid. It's a pretty good, they maybe needed one, maybe two sutures to close up the little hole that we went through. So, pretty good idea, okay? So let's see where it went from there. And everything perfect, no issues, but Balloons for Bones was born. I'm sorry, I jumped ahead to the next slide. But this was our tagline, because no one had really used balloons for this type of thing. There had been some companies, or mostly just doctors, using tools that were available to them, trying to put bone cement into these fractures. But if you don't make a nice big cavity for that bone cement to go through, you have to have it be really runny when you put it into it. And it wouldn't always stay put where they wanted it to be. And if that bone cement doesn't stay in this part of the bone and it comes back here, what runs all along right next to those vertebrae? The spinal cord. And bone cement next to a spinal cord is not a good combination. Okay, so Balloons for Bones was formed. Suddenly I'm this bone expert looking for a job, and there's this little bitty orthopedic company I had never heard of before, and I got really excited. And once I found out what they were doing, I got more excited. And about my first or second week, I inherited a spreadsheet, and this was my job, was to look at the data and figure out what was going on. So this spreadsheet contained details of every surgery that the company had done to this point with the product. There were 33 lines on the spreadsheet. So when I joined the company, they had tried this out on 33 people so far. It's a pretty new idea. And so that was pretty cool to be involved that early. But the problem was, 1 out of 3 times, the balloon popped. So that's not a really good percentage in any field, except batting. If you're batting 333, that's not too bad. But in medical device world, that's not a good percentage. So now it wasn't really a safety issue, but it was not a good product performance issue. So let me give you a little more background as far as what this looks like during an actual procedure. So this is the cartoon version of what's going on, and this would be what a physician would actually be looking at while they were using the product. So what you're looking at now is, if you can imagine a person standing sideways, and this would be the x-ray that would be coming from side to side. So, and you can see the tools coming in the balloon. The balloon is black for a couple of reasons. Any ideas what we inflated the balloon with?
Argon.
Argon. Okay, I've never gotten that answer before. But we were not inflating these with air. You think of balloons, you might think of air. But in the medical world, thinking of where we're doing these, remember I mentioned how vascular the bone is? There's lots of vessels in there, and you don't want air being right next to air vessels. There's kind of a rule in medical device. You know, air and blood do not go together, because that'll cause, we've got way too many physicians in the room for there to be any doubt about that. So we actually inflate with fluid, okay? And we actually inflate with a contrast fluid, which just means we can see it on x-ray when it shows up. So one of the reasons that it's so good to inflate with fluid also is that it's incompressible. What happens when you blow up a balloon with air and it pops?
Air explodes.
The air goes out, it's loud, is another thing. If you're working on someone's spine right next to their spinal cord, do you want loud noises to be involved? Granted, they're asleep, but still, it doesn't instill a lot of confidence. What happens when you've got a fluid-filled balloon and it gets a small hole? Yeah, I like to use the very technical terms. You just kind of, and that's what would happen. So when these balloons would pop, and I don't have a good picture of that because that's just not the best marketing material, but it would basically look like, kind of like a paintball, you know, where it would just go. And then the blood would really work to our advantage. The blood would then clear all that contrast out of the field, and then we could see our bone outlines and everything we needed to do. We would pull the balloon out, put another one in. So the other thing I want to point out in this view is that we would do two balloons. So I've got kind of a demo right here. I'm going to walk across, so this side can see, and I'll come back into the view. But so this is a vertebral body, and so we were looking at it from the side, and then now we're looking at it on end. So we've got these nice bones called pedicles on either side, where it's basically safe passage for any tools or devices that we want to go. Right in the middle, we've got where our spinal cord lives. We don't want to go there, but as long as we're in bone, we were safe. As far as we wouldn't attack, we wouldn't nick or touch any nerves or anything like that. So one of the reasons we had two balloons was so that we could cover the real estate of the entire vertebral body. Okay, so that's why we had two there. And then how do we get these images? At the time, we were using C-arm fluoroscopy, and basically that's a big X-ray machine on a pivot, and that could also detect motion. So we could look from the front, we could look from the side, and anywhere in between, because we can only see in 2 dimensions at one time. But if you choose those 2 dimensions carefully and look at it from both ways, you can basically build yourself a 3-dimensional picture and know what's going on. So, okay, why were the balloons popping? So, another engineer and I, who became very close, because this was a big problem and it encompassed all of our time, had to figure out what was wrong. We knew we probably needed a different balloon material, you know. Well, in order to change to a different balloon material, we had to prove it was better than the one we had. So the hardest thing we had to do was to build a model that our current balloons would fail at the same rate as they were in the clinic. And that proved really difficult. We were taking these balloons and rubbing them on sandpaper. And with certain grits, they wouldn't pop. We'd fill up bags of ground glass and inflate the balloon in bags of ground glass, and we'd pressurize that bag, and they wouldn't burst. Or at least, you know, not at the same rate they were in the... We baked it. We brought their temperature up. We took their temperature down. We tried to do all these different things, and we could not get them to pop the way they were in the clinic. Then one day, We tried in bone, we had tried different hardnesses of bone, different types of bone. What really was the magic ingredient here was we needed to be warm and wet. And it was really just a really neat engineering, at the time, it was really frustrating and hard, but in the end it was a really great experience of determining the mechanical properties of different plastics and extrusions to find a combination that would perform well in a warm, wet environment with bone poking out of it in all directions. So once we got our model where we could get even the balloons we thought were great to start popping, then we could find a better material that we could go with. Then once we had a different material, we couldn't just change on a dime and start making the new product. We had to test that new balloon, redo the sterilization, validate, make sure that everything about that was safe enough that we could go into people. And so that was really kind of how I cut my teeth in the engineering product development world, was kind of having this problem and then being able to solve it with a team of engineers to get through it. But it was a lot of fun. Any questions about that so far? Okay, so the question was, we had to change material. What were they made originally of, and what did we change to? And that was, so we were a company called Kyphon, working with a disease progression called kyphosis, and we had this plastic, so it became kyphoplastic. And it was a very proprietary mix as far as what it was, but it was basically a type of polyurethane, but there was a lot of science going into the extrusion, the plastics that we mixed together to create the balloon, and even just the temperatures and pressures we were making the balloons at, and how we were bonding them, and things like that. So, okay, so I'm going to move on from that. So, I have to throw a bicycle in, because I like that. I like this quote because basically, for me, things have to keep changing. I can't just do the same thing time and again. So I really enjoyed my time at Kyphon, but after we had gone through this development process, we went through a few more where we started working on different types of balloons, ones that would blow up in the front and the back of the balloon separately, so you could really control where you were applying the inflation. We made balloons that could go around a corner, so that instead of needing 2 balloons, we could get away with 1. We did ones that could go up to much higher pressures. What kind of pressures do you think these balloons were going up to? I'm working in PSI. Yeah. 250. That's a good guess. Does anyone know what a mountain bike tire gets inflated to? I heard 80. That's pretty high, but yeah, it depends on how fat the tire is. A road bike tire is going to be closer to 120. This 250. What's that?
I just said 120.
Oh, okay. And so, guess of 250. These balloons, when I started, they were 400 psi. So another challenge was, I did a lot of work, after I was on the engineering team, I started working with the marketing team to teach the sales force how to talk to physicians in a way that was intelligent and engineering enough, but also so that they could understand why it was okay to blow something, inflate, I gotta stop using blow up in the spine, but inflate something to 400 psi in someone's spine, and that's okay. And a lot of it comes down to understanding that even though it's at 450 psi, if it pops, what's going to happen? Exactly. And so I found myself working in a group called Professional Education, where I was training a lot of the sales force, training a lot of the surgeons that were going to be using this, and using the engineering knowledge that I had, the development knowledge that I had, but also getting to stand in an OR with a surgeon and making them feel really comfortable about the products that they were using, and technically so that they knew they were doing everything completely safe. Okay, so but after about 5 years, I moved on. I needed a change. So I started working with other companies that had other ideas. So now I'm just going to kind of go through kind of a cross-section of different products and fields that I was doing. So, and part of my message here is, even though I was a bone expert, I haven't worked with bones for quite a while. Let's not put a year on there. But so I found that knowledge is completely transferable to other fields. So bones are great. They're nice and stiff. You can see them on x-ray. I understood all their biology. So I had something really nice and stiff, so of course I went to work with floppy airways, which was where my next opportunity was. I was working with a company called Appion, and that was a play on the word. The disease state they were going after was apnea. Anyone know what apnea is, or just breaking it down?
It's when you lose the ability to breathe comfortably in your sleep.
I'm sorry?
Isn't it when you lose the ability to breathe in your sleep? You have to wake up.
It's not so much the ability to lose, it's not losing the ability to breathe while you're sleeping, but it's when you stop breathing. Apnea, A, without, mea is breath, so without breath. And so basically, when you're awake, you've got enough muscle tone to keep that airway open. When you sleep, and often, especially if you're on your back, your tongue and other pharyngeal muscles just become very lax and they can close. Lots of other factors that can happen with that. So this company decided, well, okay, let's keep the airway open with magnets. And so why was this kind of a neat idea? You think of magnets as attracting. What happens when you flip magnets over? They repel. And the amount of force that's needed to keep those airways open was really small. The size of the magnets that we needed to keep the airways open was actually quite small, and it was actually a pretty cool idea. In the end, that company's not around anymore to do that work. But one thing they did do before they completely gave up on the idea was actually flipped it around and went back to attracting magnets, and so basically tried to attract from the outside. But again, it's one of those things that not everything you try is going to be successful, and there might be reasons that it doesn't go on to a marketable product that may have to do with the basic technology you're using, but there can be a lot of other factors. The next company I went to was called Barosense. And if you look at the logo and look the name, Baro is a play on bariatrics. Okay? And if you can see the image up there, on the left there's a gray figure that's a little wider than the blue figure. So this was a company that was focusing on weight loss. So has anyone heard of stapling the stomach as a procedure? So basically you're trying to make the stomach much smaller as a way to make it easier for the person to not eat as much. Well, often, in the early days when they would do that, they would have to make open incisions. Then they went to bariatric surgery where they would just need a series of small incisions, and they would do the entire procedure through those incisions, and they could triangulate and do what they needed to do. Well, Barosense took it a step further and said, let's make no incisions and staple from the inside, let's go through the throat. So we developed and when I say we, I'm talking about engineers that were way more, brilliant and in skilled in these things than I was, but I was supporting them. So what you're seeing here is a stomach, there's a tube, and here comes our stapler down. This black tube is an endoscope, and those were our eyes. That's how we could see what we were doing, because you can't just stick something down in the stomach and staple willy-nilly and not see what you're doing. So that camera is going to become important in just a little bit. But I've got a little video here of how it actually worked. And just try to imagine designing and making this device work. So it comes in and we've got this membrane, and we actually pull a vacuum and suck the soft tissue of the stomach into that stapler, and then the two sides would come together and staple. And then I love that motion. The articulation involved to get it to kind of turn itself upside down. And also keep in mind the stomach is getting smaller and smaller every time we do this. Okay? So in the end, we're going to end up with a much smaller stomach. Okay? But, so there's a lot of challenges with this in that, to get all of that technology going on through the throat and being able to do what we needed to do. I was with this company for about 5 years, and then, as luck would have it, one of the next companies that I worked with, they were a video camera company. So this is actually what, world's smallest, it's one of the world's smallest video cameras. I don't know if they can still hold the title. But what's right next to it is a coffee bean. you're looking at the video camera in a bunch of copy. So this is a company from Israel, and they built these cameras. And they thought, wouldn't it be cool if we could put these cameras on the ends of medical devices? So that in barosense, when we went down the tube in the throat, we had to give up 6 millimeters for a tube so that that endoscope could go down. And it was one of the smallest endoscopes that were around. But still, our tube had to be a good 6 millimeters larger in diameter in order to be able to see what we were doing. So this company was like, I bet there's people who could use a small camera. The other thing that was really cool about this is they were using the same technology that's on your cell phone cameras, as opposed to the expensive technology that was on all of these endoscopes. So they were kind of taking this new technology and making it inexpensively enough so that you could use that device and throw it away. You wouldn't have to make it durable enough to have to reprocess it all the time. I see Dr. Wang nodding because in the colorectal field, cross-contamination of endoscopes is a huge problem. So a camera that is inexpensive, now granted we don't necessarily want to throw everything away, but in the medical device world, often that's the better thing to do. So I've got a video of this, so you can see the overtube that we used, and what you're going to see is the camera, or our device coming down, and this is a completely different mechanism for the stapler. So the other one, we kind of sucked the tissue into this membrane, and we had the two sides of the stapler coming together. This one, if you can imagine, the cartridge or the staples are up here in the silver portion. You guys can see the silver portion that's up in the throat is where the staples live, and the back end of the stapler, where the staples hit and then curve around, that's in the end of the scope. And as it's coming up, what it's trying to do is fold this tissue up against so that the stapler comes together. These green lines, what happens if your camera is right up against the skin or the side of the stomach or tissue? You can't see anything. So they said, we got a camera, we got a light, but hey, when we're up against the tissue we can't see, so let's use ultrasound. And so they built ultrasound into this device, and so the ultrasound would tell us when we were close enough that we had the right tissue thickness so that our stack of paper wasn't too thick. What happens when you staple something that's too thick? The staples won't grab. So we know exactly what thickness we were, and then we drive 2 pins in to make sure that our stapler was perfectly aligned so that we didn't miss the 2 ends. And then we would deliver the staples. Because something that could happen is up here across the top is the diaphragm. And it wouldn't be completely unforeseen that you could catch a little bit of that diaphragm. Well, you would know because it would be too thick, and you would let go. And then we would end up with, not to put 5 staples in at a time. And what we were trying to do is a treatment for gastric reflux disease. Basically trying to rebuild that valve around the esophagus and have a better outcome with that. So it was really neat going to work for this company because at this point I was doing regulatory submissions for FDA. So I had just described this transoral stapler to FDA for barosense, and now I have this transoral stapler for another company. It was the exact same FDA reviewer reviewing all my papers. So we got to know each other. She got to know my fonts and my presentation style. Okay, so another company, and I feel like everything is in twos when I look back at all the different companies. So here, had some magnets that didn't work. Now I'm going somewhere where the magnets work really well. So this is actually a chest tube company, and what they did is they had chest tubes are often placed after major heart surgery so that all that blood and tissue that's building up in there can be drained away. Or if in a traumatic injury type of thing where they need to release and they need to continue draining the blood and fluid that might build up. Well, one of the problems with chest tubes is they will clog. If enough blood is flowing through there, or maybe blood's not flowing all the time, and you get these clots, and they're very difficult to unclog once they get clogged. So this company called Pluralflow came up with a way that they had a little wire that went through with a loop on the end, and basically they wanted to pull that wire in and out to clear the blood clots. Well, it's a sterile field. You can't, you know, have something communicate with the outside that's going in and out that close to your heart. So they made it so that that wire could be moved with a magnet that was on the outside of the tube. And they moved it in and out that way. So that was like a super simple concept that worked really well. And what I did for them, because, you know, obviously they needed a bone expert to help them out with this, but I actually helped them work with a lot of their clinical data. So they would go to hospital systems and say, we've got this really great test tube, and it's going to solve your problems and make your patients recover quicker. It's going to help you out. And hospitals were like, yeah, but you cost X times as much more as this $5 one I can use off the shelf. So they actually did studies where they would compare the patients that used the regular chest tubes to their chest tube and measured their outcomes, how many days they were in the hospital, how many chest tubes needed to be changed, how often they clogged, whether they had other complications, whether they had to go back in and do another surgery because they weren't getting the blood out. And they've gotten some really great results that have been able to prove to hospitals. So even though this chest tube might cost a few times more than the plain one, you're going to more than recoup those costs over, you know, these next few patients that you're going to treat. And it's always nice working for companies where you know that the patients are going to do better if they get to use the product that you're working on. Okay? So next, again, everything. I kind of skipped over my very first job after graduate school because that was not a good fit. I was designing contact lenses. But we can talk later about how the best, worst decision you ever made in your life, and that was one of them. But this is actually a much more recent one. I found myself working for a little while for Google X. And they had the idea, I don't know if any of you recognize this. This is in the public domain, because normally a lot of those things that they're working on can't talk about. But their idea was, for diabetics, it kind of stinks that they have to, finger prick and take blood all the time when they want to measure their blood sugar. They knew that there's some research working where you can measure blood sugar in saliva, but also in tears. So they were developing a contact lens that would be able to detect the blood sugar levels in diabetics or anyone that needs to know their blood sugar. And you can see the electronics, those were all communicating with eyeglasses, and then they would get the data readouts from them. But so there was a lot of development going on because now Google has an entire division called Verily, or maybe they're broken off, or whatever the exact relationship is. But at this time, it was still kind of this little medical device niche within Google. And Google didn't have a lot of people who had experience in medical devices. And so I got the neat opportunity to go and work on a team there trying to figure out, okay, how does this giant company get a lot of the skills and things that all these little startups know how to do to get a medical device through and do all the testing and things that they need to do. So that was a neat opportunity as well. So this contact lens, I got to build on my early contact lens design experience as well. So again, different skills coming up at different times. Okay, so then, actually this is one of the companies that I'm working on now. And full circle, I'm back to balloons. But this time, it's in the cardiovascular world. So instead of balloons and bones, these are where you've probably heard of balloons being used all the time. Angioplasty, has anyone heard? So you've probably heard that, or if you've heard of people that have had a stent put in, often, basically you'll have a blood vessel, it can be in different places, but often you might hear around the heart. And they'll go in with a balloon and widen the blood vessel, or they will use a balloon to actually deliver the stent to keep that vessel open after it's been widened. Well, this company had the idea, if you've ever heard of gallstones or kidney stones, what do you associate with kidney stones? Pain, right. And part of that reason is you get these little calcifications that can block the tubes where the urine needs to drain, and that can't happen, and there's just all sorts of reasons why that is painful. And it used to be where they would have to go in and do a surgery to remove them. Well, that hasn't been the common practice for quite a while because they figured out that ultrasound can break up these kidney stones or gallstones or different stones, and they can at least make them smaller. Maybe they're able to pass, or maybe they don't have to do quite as an extensive surgery to remove these calcifications. Well, something that can also happen in blood vessels is calcification. And so this company has created a balloon that delivers ultrasound to these calcifications to break up that plaque and allow the vessel to be widened again, and then you can put a stent in it as well. Because when it's really calcified, what happens with the more traditional balloons is they can't expand it, or if they do, they might get it to expand only in one direction and not in the parts where it's really calcified. So let's take a closer look at that. So you see the vessel, and you see there's a wire, and this catheter comes in, and then the balloon inflates. And for dramatic effect, you have these sound waves going through. And what you can see is the calcium now has all sorts of cracks in it. So one of the really neat aspects about this treatment is what you don't want to have happen is to have little bits of calcium now floating around. And what they found is with this technology, they can crack it. So think about the shell of an egg, and if that cracks, but it still stays in place. It's not a great analogy, but it kind of gives you a little bit of that idea. So when you crack an egg, the shell doesn't go flying everywhere, but once it's cracked, it's much more pliable and movable. And that's what happens with these calcifications in this balloon. So this company, it's also interesting. It's at a much different stage than I've worked at before. So oftentimes, I'm starting with companies where they've got one idea and one treatment and one application that they're going for. This company, when I started working for them, they were already cleared and approved for peripheral disease. So like in the arms, or mostly below the knee, if there be lesions below the knee, in Europe and the United States. They are already cleared for, or approved for coronary arteries in Europe. They are currently doing an IDE, or basically to get the same approval in the United States for the coronary disease. They're also looking at, well, in a much earlier stage, well, what would happen if we tried to do this against actual heart valves? And so that's at a much earlier stage. So it's not a huge company. They did recently go public, but they've got all these great clinical trials going on. And so it's been really neat to see all in different countries and different patient populations and different disease states. So for me, it's been really interesting to see all those different things going on at the same time and being exposed to being able to help out with all of those aspects. Okay, so I've given you a lot of different companies that I've worked with. Not all of them are ones you've heard about or that are available today. They didn't quite make it through that funnel of marketable idea. Some of them did. Some of them are public companies, and some of them are still developing. So why do some make it and others don't? There's lots of ideas, but I think this picture is a really good one. Can you guys see what that is? Remember the last two aspects of the funnel. Does it work? And is it safe? It kind of works. Is it going to be widely adopted to have this be the new, my husband and I ride a lot of tandem, so this picture totally cracks me up. But in a very skilled, unique person, they could probably make this work and make it be safe. But your average Joe or average physician or average user, this would not be a recommended path to get from point A to point B on this particular bike. It's not the easiest thing out there. So not the best solution out there. So a lot of companies, they come up with an idea and maybe it doesn't work the way they thought it did, or it's just not the best solution. Someone else might beat them to the punch and get there first. Other ones, it might be a great technology, it might work, they might be really close to proving it in clinical trials, and they run out of money. Other ones, what you'll also find is where a big company will come in and buy up the technology and put it on a nice shelf somewhere, because now it's not competing with their existing products and things like that. So there's lots of reasons why the companies might not make it all the way through. So who decides whether or not something works and whether it's safe? I've kind of been alluding this to a little bit. In the United States, it's the FDA for the main part, okay? In Europe, there's a process called the CE mark, and that's everything's similar but different when you go to other countries. So, and then there's CanadaCAS are the main regulations that are in Canada. You've got PMDA in Japan. You've got ANVISA in some of the South American countries. And so that's been something that I've also been able to do, is to help companies navigate these different markets with trying to get clinical trials started, getting different approvals going, and getting it so that you can actually market these products. So within FDA, and this is just kind of a real brief overview, but there's three main classes of device. So any of the medical devices, all of the ones that we listed, everyone that you could define, or that you could think of, is going to either fall under class 1, class 2, or class 3. And that's risk-based. So the ones that are in class 1 are much lower risk than the ones in class 3. And there's different rules and regulations that you have to abide by in order to be able to sell anything that's in any of these classes. So one of the niches that I've really been spending the last several years is working with companies sometimes to figure out which path are we on, which way, how can we get to a market clearance with a product. And sometimes you might start with something that's in one class and then you build into the next class so that you have a product that you can work with. Has anyone ever heard of a 510K? Is that a term you've heard? The 510K is a process to get a product approved by FDA where you basically say, we are just as safe and effective as something else that's out there, okay? Which can be a challenge when, from a product development point of view and a patent point of view, you want to make yourself seem absolutely different, completely different than anything else that's out there. That is not how you want FDA to think about you. So with that bone tamp, the balloon and the bones in the balloon in the bone, we compared it to a bone tamp, which a bone tamp is basically a curved screw. To me, it looks like a curved screwdriver that physicians would go in with bone and they would make these bone cavities out of them. And we can also compare it to other balloons that were out there, and we were able to. This was before I joined the company, but they were able to convince FDA that, okay, these have enough similarities, yes, it's okay, you can go ahead and start using this product, okay? And so that's a really neat process that I'm involved with some of these other companies that I'm working with right now. So 510K is where we're just like something else. The next level up with class 3, most class 3s, you're going to have to do some clinical trials to do this. You're going to have to go to what's called a panel and have all your results thoroughly vetted, and it's a much more rigorous process. And it's something that is sometimes strategic, because if you have to go through this process, then anyone else who wants to compete with you will also then have to go through that same process. So going through that process isn't necessarily a bad decision. It's kind of just a reality of the type of device that you have. But something that I've done with some companies is we will get a product cleared through 510K. For example, that stapler that we were doing on the stomach, we got a very generic form of the stapler approved that was, basically it said we could oppose any tissue. That went through, and we could technically sell it. But the way it works out is, as soon as we started saying we wanted to do it in the stomach for obesity, then we needed to do some clinical trials to show FDA that that was going to work for us. But having that generic stapler there, as our example, we have all the paperwork that shows our materials are good, our design process is good, we're safe, we're not going to hurt anybody with this. It just makes that approval process go much more smoothly. Okay? Okay. So I wanted to kind of wrap up with another story, and it has to be a bicycle involved. So this is my friend Ken, and Ken and my husband and I, we've cycled a lot of what I like to call stupid distances together. But Ken does it slightly more stupidly than we do, and that he likes to do it on a fixed gear, which, okay, so, and for those of you who don't know that you should be groaning right now, a fixed gear is where you have one gear and no freewheel. So if your wheel goes around, your pedals go around. So imagine yourself like when you go down a hill on a bicycle, you like to coast, gives you a little break. No, you go really fast. And when I say stupid distances, I'm talking 200 miles in a day kind of thing. But anyway, so Ken bikes a lot. Ken is a very seasoned cyclist. Ken bikes to and from work. So he's also a Facebook friend. So one day we're on Facebook and he's like, yeah, I'm okay. And then I started getting more of the backstory. So he was biking to work and he went over the handlebars. He landed on his head. So what does he do? He dusts himself off and reattaches his front wheel, because that was a problem. He didn't have it tightened quite enough, and he rode to work. He started being in a lot of pain, and finally his coworkers were like, you need to go see a doctor. When he did go to a doctor a couple of days later, they took him to surgery pretty quickly. And so, about a week goes by, and he's like, he's out of the hospital and everything, and a bunch of us decide to get together for dinner and everything. And he was telling us what they did for him. He's like, I don't know what they did, but somehow they put some balloons in my bones, and they fixed the fractures in my spine. So when I was working with Typhon, we were all focused on the vertebral compression fractures. But since then, they've gone after this different market, which is traumatic fractures. And this is not Ken's x-ray. I do love to collect my friends' x-rays, but I've spared them putting it. So this is one from a case study that I found in a journal. But what's different here is this looks kind of familiar in that, it's a vertebral body that's not very square anymore. And a trained eye will see there's a definite fracture along that front end. Now, with traumatic fractures, they're going to get another type of imaging. They're going to get some CT images so they can really know what's going on in 3 dimensions. And what you're seeing here in the middle frame, you're kind of looking at the vertebral body as it slices, or you're looking at it from the top. And all these lines to the vertebral body, they're not supposed to be there. What's good about this is this nice solid line between the vertebral body and the spinal column. Okay, so the back part of the vertebral body is completely intact, and that's a good thing. But it makes it a really good candidate for kyphoplasty. So they go in with the balloons. They kind of they don't blow up quite as big because there's a lot of healthy bone, but they kind of push the fractures, put the end plates back where they're kind of supposed to be, and they've got enough of a cavity so it's a nice thick cement that's going to stay where they want it to stay, and they can fix that fracture, whereas previously they probably would have had to do some sort of rods and screws in the vertebral bodies above and below. So this was one of those really unexpected instances where about much closer to 20 years than I want to admit, after me and my friend Ryan were trying to figure out why these balloons were popping all the time, suddenly this same technology comes around and directly impacts a close personal friend of mine. And so that's just really a neat life cycle that I hope you all get to experience sometime. And with that, I can start entertaining questions. I do have a couple more pictures up here. One is of my favorite tandem partner, who you'll get to listen to tomorrow when he lectures in front of our tiny house that we built. So another conversation starter. And our favorite vehicle to go to and from, which is the tandem. But also just kind of this image of, a lot of people when they think of their careers and where they want to be, sometimes you only think about the big leader duck out in front, calling the shots, or maybe you see yourself as one of the followers following in line, but every once in a while, taking the other path can lead you to some really good adventures. And the quote underneath, if you can't quite read it, is not so much where we are, but how we got there. So, thank you very much for your time and attention. So I'm going to repeat that. So the question was, when you've got that vertebral fracture and the bone is angled, when you inflate the balloon, why doesn't it break the bone as opposed to being able to move it? So if you think of the vertebral bodies as kind of like a tin can, and so and the tin can is filled with something, but the outside of the can is made of a stronger material than what's on the inside. So the tops and the bottoms and the sides are more rigid and act more like plates often. So like you can imagine if when you put that balloon in, it can act like a jack and kind of lift that whole plate up. And the stuff holding the two ends together is kind of compromised and has been squished down, so you're kind of trying to push it up. It doesn't always work. And so sometimes if you would see that the balloon is kind of popping through the plates on the end, or they're called end plates actually, on the top or the bottom, you would stop. You'd get as big of a hole as you could, get that cement in there, because even if you don't restore the anatomy, you probably still have a very good chance of helping the pain and keeping the patient in a much better state moving forward. Why doesn't the side break? Part of it is the position, in that as we're inflating, we don't touch the sides. So it's kind of this real spongy bone on the inside, so as you're inflating, it's just kind of compressing that all together. So until you actually get up against the sides, you wouldn't break. But the other thing is we do look at it in 2 dimensions so that we stop as soon as we start approaching any of the sides, because we wouldn't want the balloon to pop out the side. Does that start, or maybe we can talk about it a little bit more. I think maybe a drawing or something might help it as well.
How are you safely able to inflate these balloons at such high pressures without leaving the patient at risk?
So how can we inflate these balloons at such high pressures safely without giving the patient a risk? So what types of risk? Or
Well, if the balloon popping, for example, could cause catastrophic. Think about the amount of pressure and how possibly explosive.
So it was kind of, so like with the balloon, why isn't it explosive? And part of it is because it's that fluid, which is incompressible. Like you can't squash water, at least not at the pressures we're talking about. So, and these balloons will expand, and as soon as there's a hole, that pressure goes to 0 immediately. So it's not maintained. Now there are other balloons that are made to not expand. Once you get them, they're made to go to a particular size, and so they have a completely different pressure profile. But it's really amazing to just kind of interact with them and play with them, because they're not catastrophic. Because if you blow them up with the air, they're catastrophic, and like you'll get bits of balloons going apart just like a little party balloon. But because there's no air involved, it's all water. It just goes. So hopefully that gives you a little play with some balloons. It's really cool. Okay, I'll give it.
Do you see balloons helping with any other problems in the spine, or just back?
So the question is, do I see balloons helping with other problems in the spine? There's actually, I'm less up to date with what's really active right now, but there have been attempts to have balloons be in the disc space, so in between the bones, and also other places. So it's either been kind of in the bone or between the bones as far as the spine goes. But we actually, there have been companies then going lower, so into the sacrum and into other bones, or in the femur. Sometimes like if it's a collapsed femoral head, the ball of the femur, if they can kind of push that up and preserve that cartilage layer and get it to be a better anatomy, they can delay the time until the patient would need to have a hip replacement. That's been another area. There have been, so we were kyphoplasty because we were kyphosis. There was another balloon or company a few years later that said they had sinuplasty, and some of our marketing people went there, and so there's a lot of parallels in their marketing, like the same purple is appearing. But they had sinuplasty, where they were doing for chronic sinusitis. So they were, balloons for noses just didn't quite have the same ring, and so they had a better tagline that they came up with. But so there's balloons everywhere. So,
What happened when you do the contacts? Did they ever go to the market, or were they stopped in development, or is still in development?
so the question until it is ready to go or it gets to a point where they're more public about their information, I can only guess. That's why I was very careful that, what I said was stuff I could find in the public domain.
For the device that helped with the classification side of things, what did it do after cracking that substance?
Oh, okay, so the question was for the balloon that goes through the arteries and was cracking the calcium in there, what happens to the balloon afterwards, right?
As well as the classification system.
Okay, so the calcification, the idea is that it gets all cracked and it stays where it is. It's actually it's one with the whole vessel wall. It's kind of it's more in the vessel wall than necessarily all inside the vessel wall. It's all attached in one. So that basically everything gets widened and can be pushed out. So this balloon gets deflated and pulled out, and then another device will be coming in, and often with a balloon in the center, and they'll put a stent there to hold it nice and large and open, and then take that out. So the balloons in all these cases get removed. They don't stay there. I might not have been really clear about that.
So, balloons and arteries are pretty different. So what are the differences in the balloon mechanics between the ones that fit the spine and the ones that fit the artery?
Okay, so the question was, what's the difference between the balloon mechanics between the ones that are in the balloon or in the bone versus the ones that are in the arteries? And that's a really good point. They're all balloons, but they have very different elastic materials. So our material, the balloons were made to go big and withstand a high pressure. Okay. Now the ones in the most cardiovascular balloons are more so designed to go up to a particular diameter and not get any bigger. And that kind of makes sense because you don't want to be able to basically create an aneurysm inside of a vessel. So it's all side, and so they'll measure ahead of time and say, okay, I want a 5 millimeter diameter balloon. They'll put a balloon in there that cannot go larger than 5 millimeters. And the pressure profiles are completely different. So one of the things with the shockwave balloon, they were operating at about 4 atmospheres, which, so 60-ish, not quite 60 psi. So a much lower pressure, but they don't go beyond a certain size. And then for the initial, when they're doing because when they're delivering the ultrasound, they want to be kind of up against everything, but they don't want to be exerting a lot of force. They just want to be making contact. Then after they've cracked the calcium, then they'll go up a little further to kind of push and make the vessel larger, but they're not delivering the ultrasound at the same time. Then they pull out that balloon, and then they go in with a stent that will fill up that whole area.
And they're also filled with saline, I guess?
They do use a form of saline, and also, but then, so another commonality between those balloons that I didn't point out, but they both had marker bands that would show up, so you'd always know where the ends of your balloon are, because the plastics that you're using, you can't see that on X-ray, unless you make a plastic that has some radiopaque material in it. That's one way you can do it, but then sometimes you can't see. That blocks your field too much. So they'll usually put marker bands on either end, but then show you where the ends of the balloon are. Now our balloon, the balloons for bones, when you blow them up and they grow up in size, those marker bands would also move. Like the inner member of the balloon that connected the back part of the balloon to the front part of the balloon, there's a little member in there, little tube, so you can attach those marker bands. That would actually, the balloon when it came out would be much longer and fatter than when it went in.
I was trying to plan my inner city, try to be more
Okay.
And so I really appreciated the engineering aesthetic. I'm familiar about the spinal line and all these stuff. So one person's already been asked why the balloon doesn't necessarily expand beyond society. But I wanted to ask one more with the stomach. And it's kind of about the staples and patient safety. So how does does it choose to an increased probability of ulcers or maybe even a certain problem with students?
Okay, so he was mentioning that he was kind of playing letting his inner cynic come out and trying to look at this from the point of view of the FDA or something like that. So when he was thinking about the particularly the stomach product, like wouldn't working in there lead to more like ulcers or other problems in the stomach, like problems with the staples and things like that. One thing that you'll learn when you start working with stomachs is they are really durable. You can put a lot of stuff in a stomach and it's amazing what it'll handle. But on the other hand, we would make everything with very smooth edges. We would cover things in plastic, like metals would get covered in plastic, so there was no chance of creating scratches because you wouldn't want to injure the stomach when, like just by passing your tools and things around it, because it is possible to injure that. So we took a lot of precautions to make that as non-traumatic as possible. Also did a lot of testing on cadaver models and also some live animal models. You have to, because you would, not only could you do it, you needed to know that it was okay at the time that you did it, and that over time, for example, with the staples and the way we were doing things, that was okay over time. So a lot of it is you have to be a critic within the company and not just have the blinders that we have the best answer ever. We need to prove this. One internal metric that I like to use, and this was really true with Python, is where the mentality started, was, would you let your grandma have this procedure? And that was, what I want. And as soon as I started hearing surgeons describe our procedure as the kisses and hugs procedure, where they would have these patients, because as a spinal surgeon, a lot of times you have to make it a lot worse before things can get better. And suddenly they had this procedure that was really easy, and then they put a couple Band-Aids on at the end, and the patients would wake up, and these little old ladies, I hate to use that description, but if you can imagine the scenario where, the patient would wake up and give the surgeon a kiss and a hug, and be so grateful that they took away their pain. And that's a really neat, so those are kind of the metrics of how, as an engineer, you're making sure that things are safe. So hopefully that explains it. How are we doing on time?
15 minutes.
Oh, okay, sorry. Yes.
Can you talk a little bit more about bone cement? How, what's it made of? How long does it last in the body? Are there any other applications other than healing this with fractures and stuff like that?
Okay, so the question was, what about bone cement? What is that stuff? Was kind of the
Yeah.
So it's polymethyl methacrylate, so it's a polymer.
Okay.
And with a lot of polymers, you take two parts and you mix it together. And with this particular one, you have a powder and a liquid, and you mix it together, and it actually heats up, which is another issue. When you're engineers and you're playing, you can hold a little bit of PMMA in your hand and play with it and watch it as it gets hard and mold it and everything. But so it's kind of mean, but you can give someone who doesn't know about it, like a golf ball size of it, and say, hold this, do whatever you do, don't drop it. And it gets really hot. But,
So it's an acrylate that is actually similar to super glue.
no, it's not an adhesive.
Okay.
This one is not. So it's polymethyl methacrylate, as opposed to cyanoacrylate, which is super glue, which is like a skin, often used for skin closures. The other thing about PMA, it was actually discovered to be really biocompatible, meaning the body doesn't react. It won't start attacking it, trying to remove it too often. Fighter pilots, there were some windshields, as I understand it, or made in planes, and then they would get parts of this material in their eyes, and it didn't cause a huge reaction. And that's in the way early aspects of when they found out that it would be a good material. At least that's what I remember learning very long. I hope I haven't butchered that story too much. But it is a very generic plastic that was used for a lot of different things. In graduate school, we would use it for potting and holding things. Because if you needed to create a test fixture around bones, like if you wanted to be testing a couple of bone ends, well, you needed something that would hold that really strongly, and you could use this material for that. Since then, so this was, I hate dating myself, this was around 1999 was when I started with this company. And polymethyl methacrylate was the only material. Then there were other companies that were basically coming out with alternatives to bone cement, more biological materials, materials that could actually be absorbed by the bone, replaced by bone. So that in an older person with a compression fracture, having this bone cement might not be the worst thing. But in a younger person with a traumatic fracture, if they're only 20 years old, it would be, their bones are actually still able to heal quite well. So having a biologically active one or something that the body could resorb and replace it with real bone is a better solution. So there's been, actually lots of development in that area. But it's not an adhesive. It was also used for securing hip implants and knee implants. Sometimes when it wears, like if you have two surfaces coming against each other, the tiny particles of PMMA can get into the bloods, and that can cause some issues. So the orthopedic fields kind of went completely away from it, and now it's kind of coming back because some of the alternative solutions weren't as great. So I'm going to go to this side room. Okay, on the end?
So for the blood work that
I'm sorry, the blood work?
the blood
Oh, yeah.
how does stretching that out of it so that you into like the blood was actually flowing and that size, are the walls that are there for like stretch and strength that allows more bodies to grow, or how do you do that?
Okay, so the question is, when you've got this artery that's been hardened and you crack it and now you made it bigger, isn't that making it bigger kind of a problem? So first off, I'm going to admit I'm new to the cardiovascular field, so I'm not the complete expert on it. I'm learning new stuff every day. But in general, the real thing that you're trying to solve is that calcification is preventing enough blood flow. So it's not big enough the way it is. So we need to make it better by even the act of cracking it will make it a little bigger, and if we can spread it out so that that hole is wide enough to get a good flow again, that's the main goal. If you go too far, yeah, and that's absolutely one of the reasons this shockwave is a solution that a lot of people are gravitating towards, is when you don't crack that calcium first, and if you just try to take a traditional balloon in there, if it's not solid calcium all the way around, if it's solid calcium all the way around, the balloon's not going to be able to expand it. If it's not solid all the way around, the balloon's only going to expand the weakest part of the vessel, and that you do run the risk then of creating what's called a dissection, and that's when the vessel does actually split. And then they have other methods to address that, different types of stents and things that they would need to go and repair that. So, and you had a question right next.
This might be a little tangential, but I understand from the recent controversy about the Apple Watch and the picture. I was wondering if you could elaborate about how that changes its classification in the FDA system. Maybe get your opinions on self-diagnosis type.
Okay, so actually it's a really neat question. So the question relates to iWatches and other devices that might have features such as, you said EKG. So basically devices that would allow a typical consumer to diagnose, maybe recommend treatment, or that medical decisions could be made out of. And that definitely changes the classification. So it was really interesting when all these devices were first starting, because people didn't know what to do with them. Many companies that didn't have experience with medical devices didn't know that the FDA would even care that they, and I'm looking at the Fitbit guy. Because they weren't in the medical device world, they're like, why would the FDA even care about? And meanwhile, the FDA is looking at all these devices saying, hey, we need to make sure that we don't have some device that's telling a diabetic whether or not they need to increase their insulin, or telling someone whether or not their heart is having a problem or not. But at the same time, someone should be able to go ride their bicycle and know what their heart rate is, and they're not making any medical decisions. I mean, I look at a heart rate monitor and I'm like, yeah, I need to slow down. You know, I don't have a problem with that type of feedback. So it took a while, but FDA actually came to, and a whole new guidance came out, you know, many, many pages of the FDA's best thinking of how they were going to handle this type of device. So they gave some really good guidelines, and basically you'll see a lot of companies that will make absolutely no claims as far as diagnosis, or, you know, that, you know, always, you know, check with your medical professional. This is strictly for fitness monitoring or things like that, because that keeps you into a category where the FDA has decided to exercise enforcement discretion. And that basically means, for the most part, they're not going to get involved, but it's enforcement discretion. They can still decide if they see someone just blatantly, you know, for example, selling a device where people are, you know, it's pretty clear that they want people to be diagnosing or treating or something like that, then it gives them the ability to get involved and make sure that people are still safe. So it's a very dynamic field, and people and companies are really trying to figure out how to thread that needle correctly, without being completely bogged down in that a fitness monitoring device really shouldn't have to go through the same hoops as a balloon that's widening arteries around the heart. You know, there should be some difference in the types of things you need to do.
2 more questions.
Okay. Oh, lucky blue.
Did you ever think about using non-nutritive fluids to fill the balloons?
Sorry, couldn't quite hear that?
Did you ever consider filling the balloons with a non-nutritive fluid on the side?
Did we ever consider filling the balloons with a non-Newtonian fluid? I'm going to say I never thought of it. And I don't really know of too much, but the other thing is, so what we were filling the devices with were fluids and things that were already on the shelf and in the tool bag of the physicians and already available. So we did not have to do any testing to show that this contrast we were using could be injected directly into blood vessels, and it was proven to be okay. If we would have started going with other fluids and other fillers, then we would have been becoming a contrast agent type of company, and that would have been a whole other field of expertise. So from our purposes, we were the balloon ones, and we used other inflation things that were readily available. But it's a neat thought experiment. And it might be out there. Someone else might be in stealth mode, totally looking at stuff like that. Yeah. So we have one more. Oh, you already got to go, so I'm going to give someone new a chance. But you can talk to me after.
So you know how you mentioned the FDA has like 3 classes of regulation?
Mm-hmm.
Can you give like some examples of each class, just like get a general idea of like what?
Okay, so the question was, there are 3 classes of devices, and so give examples of 3 devices that are in each one of them. So for almost everything that I've worked on has been in class 2, that 510K route. I'm trying to think of all the examples I showed you. The magnets in the throat, those were implants, and that almost automatically kicks you up into class 3. So those were class 3 devices. So we definitely needed to do clinical trials and do a lot of things preliminarily before we could move on with that. The other class 3, the balloon in the blood vessels, there's aspects of that that are also class 3, but there's other parts of the system that are class 2 and below. The chest tubes in general are class 1, but this particular chest tube is cleared under class 2. So Band-Aids, toothbrushes, all that, class 1. Scalpels that, you know, a surgeon uses, class 1. But, and you think of that, well, you know, you can do a lot of damage with a scalpel, but it's such a simple tool that that's where they have to rely on the expertise of the surgeon who's using the scalpel. So that's a class 1. But if I made a scalpel to cut the cornea of the eye, then suddenly I'm in a different class, because it has a lot to do with not only how you intend to use it, but where you intend to use it. It goes into figuring out those classes. So, thank you so much.